Hello and welcome. In this lecture, I will give you an update on the menopause, evidence-based update, and on hormone replacement therapy, HRT. The modern terminology of it is menopause hormonal therapy, MHT. I am Shagaf Bakour, Director of Medical Education Phase 2 and Year 4 Lead at Aston Medical School. The topic is frequently viewed as rather complex. I hope that this talk will streamline things for you so you can go away with take-home messages. At the same time, I would like to apologize for not being able to utilize the video function, so my picture is not there. This is because my PowerPoint on this laptop does not support the function of the camera and videoing, picture-in-picture in particular. Apology for that. It is quite important to get the definitions right. So menopause is a term. Meno means menstruation, pause means stop. So menopause is when the menstruation stops permanently due to the loss of ovarian follicular activity. And this usually occurs with the final menstrual period and for the following 12 months. In the UK, the mean age for the menopause is 51 years of age. Following 12 months of amenorrhea, it's called postmenopausal status. Usually what happens, any time between the age of 45 to 50, periods starts to become irregular, maybe spaced. The woman starts to miss some periods. This happens up until the period stops gradually, and for the following 12 months, all this time, between the time that the period starts to become irregular and spaced, up until 12 months after final menstrual period, this is called perimenopause. Now, if the period stopped between the age of 40 and 45, this is early menopause. And if the period stopped before the age of 40, then it's premature ovarian insufficiency. In other words, between the age of 45 to 50 is when we expect the period to start to become irregular, spaced, missing some periods, and gradually stops completely. And all that time between that age and 12 months from the final menstrual period, it's called perimenopause. I hope this clears things for you for further slides when we talk about other definitions. How do we diagnose the perimenopause or the menopause? Well, this condition should be suspected if the woman started to have the change in the menstruation pattern and having symptoms. What are the symptoms of reducing circulating estrogen? It's basically three main things. It's the vasomotor symptoms, including hot flushes, night sweats, mood swings, and that is followed by obviously sleep disturbances. If you are waking up all that time with hot flushes, that gives you fatigue next day and unable to focus and concentrate, so cognitive. And then we have the local urogenital symptoms because of the reduction of the estrogen, vulval dryness, and perhaps altered sexual function. So we do not need to do hormonal assay, mainly FSH assay, in a woman above the age of 45 who is healthy and started to have these typical symptoms of the menopause. So clinically, we can make the diagnosis. However, we will need to do the FSH levels when the women are having Atypical symptoms above the age of 45, as we said, age of 45 onwards is the expected time to have those disturbances. But if those symptoms are atypical and the woman above the age of 45, we need to do the FSH. We need to do it also early, as we said, between 40 and 45 or before the age of 40, because those are not expected ages for periods to stop. This is about the assessment of women with a suspected menopause. So someone coming with the age of 47 with spaced periods, or the other way around, irregular periods with hot flushes, vaginal dryness, how we are going to approach the assessment. So we need to ask about all these symptoms in details. We need to see how much it has an impact on her life, occupational life, marital life, domestic life, family life, and we need to ask about the lifestyle. I mean, some working women full-time will be quite really miserable with quality of life if they have had all these hot flushes disturbing them. Visibly, they can be look distressed and quite flushed in meetings and among people. We need to know the contraception. This is quite important. We need to follow the UK contraceptive and sexual health guidelines, which is to use the contraceptive method for 1 year if the period stopped above the age of 50, and for 2 years if the period stopped before the age of 50. So we need to ask about contraception, so we do not end with theoretically late age unwanted pregnancy, smear status, family history, previous treatments, hormonal or non-hormonal. What's her wish? What is she here for? Is she here just for reassurances that this is the natural menopause, or she's pursuing hormone replacement therapy or other alternative? What's her current medication? Because we know some medication can be intervening or influencing the symptoms, like in particular anxiety and depression disorders. And what comorbidity we have, as you know, diabetes, strokes or family history of strokes, previous DVT, those are relatively influencing our decision to commence HRT or not. They are not completely contraindication, but we need to be mindful of. So I put here those as a aid memoir, how to approach specifically the history when we are considering the menopause and HRT. So the management also, it's not just medication and prescription. We know now that there is some other type of prescribing, like lifestyle changes, and this is for healthier lifestyle with the menopause and without. For example, advise, give more information about the condition, inform the decision of the women, support, and things like exercise, weight loss, because with the menopause, ultimately there will be change in the metabolism rate and invariably weight gain. And with that it comes as well, with the symptoms, comes some anxiety and stress. Therefore, you need to be aware of that and really have the insight into how general advice can actually quite be helpful for these women. Also, we need to start screening, for example, mammography for breast cancer, and bone health, which is the DEXA scan that we do to screen for osteoporosis. And obviously, again, I'll check that you will not forget the contraception. If the woman is not keen on HRT, then we can talk about other alternatives in the form of CBT. If the vaginal dryness is what bothering her, then we give vaginal moisturizers and lubricants. We can also arrange follow-up to see how she is getting on with this non-hormonal options. And if there is overlapping with mental health problem, such as depressive and anxiety disorders, which is very common, then antidepressants. We could use also some pain management, like, for example, gabapentin that works on specific pain pathways. Obviously, we can involve the pain management clinicians with those decisions. And the main thing is to ensure that we need to refer her to a specialist who probably more knowledgeable than the generalist or general gynecologist, the HRT specialist or the menopause specialist, if we are not sure at all, or if the symptoms continues, or if we are not sure of what's overlapping with other systems. Or if we have a woman who stopped her period quite early, because those type of women with premature ovarian insufficiency, they need a specific, knowledgeable specialist who can attend to their needs, particularly bone health. So the hormone replacement therapy has been available for us over the last 80 years, since 1940s. The first preparation was the conjugate equine estrogen. It's referred to as CEE, and it's from horses, basically, horses' urine. Then, about 25 years ago, we had this drama with the press release that accompanied one of the very large randomized control trial, the WHI, associating giving HRT with higher incidence of breast cancer and stopping the RCT prematurely. Since then, the culture was to avoid using HRT, and the HRT companies were prevented from seeing clinicians or promoting the products. However, we moved now way for the last at least 8-10 years away from this very restrictive approach to the really more liberal one, with the consensus that we have from experts around the world on how and about the indication to use it. And as I said, mainly we will use it for the menopausal symptoms, the vasomotor symptoms, menopausal symptoms, as HRT is superior in randomized control trial in controlling those symptoms with in excess to 90% success rate. And again, the woman can use it with her choice as long as she wishes to control her symptoms with adequate counseling. And with the liberal usage of the topical vaginal estrogen, menopausal hormonal treatment. So this remains our main take-home message as principles for considering HRT. So first of all, you need to be well knowledgeable in order to transfer your knowledge so that you can give the woman informed choice about the preparation, about the route of administration, and about risks and benefits. Then we will need always to keep in mind that we can prescribe the lowest dose for the shortest duration that actually controls the symptoms. The main indication, the main principal indication for prescribing HRT is for the menopausal symptoms. It's not the first line treatment for osteoporosis or cardioprotection or anything like that. The main fundamental reason we go for HRT is for menopausal symptoms, the three areas I covered in the previous slides. This is because randomized control trials showed that HRT is superior in controlling those symptoms, and it's successful in over 90% of women. Now here in red, I put it for you to remember that we need to distinguish between these two types of prescribing. For women that still have their uterus intact, we need to give estrogen and progestogens so that we balance the effect of estrogen on the endometrium, and this is for endometrial protection. We give the progestogen as well. While for women who had hysterectomy, we can only give estrogen, and we do not need to add additional hormone with its own bespoke side effect. Particularly the modern understanding that progestogen as well is linked somehow to breast cancer, not just estrogen. So I repeat again, for the women who had their uterus intact, we need to give estrogen and progestogen in considering HRT, while for women who had hysterectomy, there is no need to add progestogen. We just give estrogen-based HRT, and that is safe. The only reason we add progestogen to the HRT is for endometrial protection. And I will reiterate this message as I go along. If the woman has urogenital symptoms, we can give vaginal estrogen as first-line management. And we need to arrange follow-up for these women to look at the efficacy and tolerability and adjust doses, adjust mode of administration, or even advise to stop HRT if needed. You cannot just prescribe it and send her off. I covered this slide already, but you will find that I'm reiterating the message so that you are very clear about it. So we are saying that HRT primarily is used for vasomotor symptoms, hot flushes, night sweats, mood swings, and sleep disturbances, anxiety, muscle pain, arthralgia, urogenital symptoms. And also it's known now that HRT is bone protective, cardioprotective, but those are not the primary prescribing indication for those, except in premature menopause and premature ovarian insufficiency, whereby HRT is given also to protect bones and for cardio protection. So we did say that one of the main principle or key principle for prescribing is to start with lower dose. So why to start with lower dose? Well, it's common sense. If we are starting with lower dose, then hopefully we're having fewer major adverse effects such as VTE, venous thrombosis, or stroke, DVT or stroke. Also, it may reduce the risk of breast cancer. This is again logically, but not yet proven in the type 1 evidence. And also, the menopause symptoms can be controlled by a lower dose of HRT. Then why to give the bigger dose? We have publication to support that. And the lower dose as well have been shown that it can be used to, it can prevent osteoporosis, with also few publications supporting that. So that's why we can use lower dose and have the same efficacy on the symptoms. So we start now to talk about how we are going to give HRT, and this message will come over and over again. So we can give it orally, which is the most acceptable method for probably women, because they have used before their contraceptive pills and it's something similar. Maybe it's also cheaper. So again, estrogen only for hysterectomized women and estrogen plus progestogen tablet for women with uterus. How we give this combination? We either give it as sequential combined, whereby the first 14 days of the cycle we give estrogen only, and the second 14 days of the cycle we give estrogen and progestogen in each tablet, and this will produce cyclical bleed or period. Or we can give continuous combine, whereby each tablet over the 28 tablet or days, each tablet will have a combination of estrogen and progestogen, and this will not produce period and will be the period free. Right. So although we say orally or as tablet is the most common administration route, more recently we are moving towards transdermally. This is patch or gel. So the transdermally route becomes the gold standard, as the hormones will go straight to the bloodstream that is supplying the skin, and that compares favorably if we think about tablets being absorbed through the GI system. So some of the substance will be, or the hormones will be lost, and some will be absorbed. we can't actually quantify how much will be lost with the excretions and how much will be absorbed. Hence, the transdermally one is more efficient, and we can monitor it more accurately. Also, the transdermally approach is more cardioprotection and less influencing the lipid profile compared to orally, and therefore it's favorable for cardiac conditions. And thirdly, it's safe in women that are themselves high risk for thrombosis, such as the obese women, the smokers, those who have migraines that are really dreading taking estrogen, in particular hormones, as there is evidence that the transdermally will not increase the bouts of migraine. Also epileptic women, as the transdermally will not increase the frequency of the fits, or women with gallstones. And finally, some women do not absorb via the skin well, hence it's difficult to reach therapeutic level, and this we have to keep in mind if the symptoms continued in spite of ensuring that we are optimizing the dose. So this is now transdermally. And another way or route of giving the hormones is implant. The implant is estrogen only. There is no progestogen implant. It's still available, although difficult to obtain. So in tertiary centers, still there is some supplies. However, the disadvantage is it needs invasive procedure involving an incision and a suture, so you can embed the implant in the subcutaneous area, and then maybe a stitch or a plaster to close it, and that need to be repeated every 6 months. And the last route of administration is the vaginal estrogen, which is the topical route. Okay, so progestogen for endometrial protection. By the way, we say the word or the term progestogen for the synthetic external progesterone. So the long-term unopposed estrogen effect on the endometrium will result in endometrial thickness, and that can harbor abnormal cells called hyperplasia cells and can become atypia, and then sometime down the line can progress and become cancer, endometrial cancer. And therefore, the high estrogen high circulating estrogen levels without opposition by or neutralization by progestogen is high risk for endometrial cancer via the hyperplasia route. Therefore, remember, the only benefit of adding progestogen is for endometrial protection. Learn that. I'm repeating it all the time, so you are actually quite happy with this notion. And therefore, women with uterus must have progestogen as well as estrogen. So how we are going to add the progestogen? We can add it as oral preparation, either sequentially, as I explained in the previous slides. So the first half of the cycle, each day, the tablet we are giving has estrogen, and the second half of the cycle, each tablet in the HRT has a combination of estrogen and progestogen, mimicking the physiological cycle. And therefore, this type of administration will present in regular withdrawals or periods, and therefore we give it for the women perimenopausal who are still not completely amenorrheic. While we can give the progestogen in a continuous combined manner, we call it the bleed-free, whereby the whole 28-day cycle tablets, each tablet has got small amount of estrogen and progestogen combined continuously without any break, and the expectation is there will be no bleed, and we specifically give it for women who are at least 1 year after the menopause, so that we do not induce periods after she had amenorrhea. So that's one route of adding progestogen. We can give it as orally as I described, or we can give it as a in the patch, again, either combined with the combined continuous with the estrogen, or combined but sequential with the estrogen, exactly like the tablet, but as patches. Or we can give it vaginal, so we can give the estrogen separate, orally or patches preferably, and we add progestogen vaginal tablet. Or we can give it as hormonal coil. So the hormonal coil is there, works as the progestogen arm of HRT, and it's licensed for 5 years. And we can only add then estrogen patches, and that will, the hormonal coil is licensed for endometrial protection. In fact, this would be excellent choice for those women who still need contraception. Remember how we said the contraceptive and sexual health guidelines says if the menopause happened less than 50 years, we need to continue use contraception for 1 year from last period. And if the menopause happened before the age of 50, then we need to use it for 2 years since last period. I'm referring here to contraception. The hormonal coil need to be changed every 5 years. And now to sum up, the routes of administration for hormones can be oral, which means tablets, estrogen-only tablets, progestogen-only tablets, or combined. There is also, I will explain about SERM, selective estrogen receptor modulators, and later on in the slides I will explain about it, mainly for new modern advances for urogenital atrophy. Or the hormones can be given as transdermal. This is patches, gel or spray, or subcutaneous, which is the implants, or vaginal, can be in the form of rings or tablets, creams, pessaries, or gel as well. Again here, I'll later touch base on dehydroepiandrosterone, DHEA as well later on. And finally, the intrauterine, which is progesterone-only hormonal coil. This slide is self-explanatory and summarizes what we said already. Those women without uterus, we only need to use estrogen continuously without a break and without a bleed. Women with uterus, we need to use estrogen and progestogen, and that summarizes how we are giving it. In the combined sequential, the first half of the cycle estrogen, and the last 14 days estrogen and progestogen tablet in each tablet in those 14 days, and you will get period regularly. We call it regular withdrawals. Or we can give it for older ladies who have stopped periods for at least a year as continuous combined. As you can see, every day in the cycle, each tablet has got estrogen and progestogen, and this will not induce any periods. This slide is to give you visual examples so you understand completely. This is the way the pack looks when we are giving it as sequential combined for women with uterus, and when we need to continue having regular withdrawal. Femostin, 1 is Estradiol, and 10 is Progestogen. And we like those dihydroprogesterone because it's very much close in composition to the natural progesterone, and the estradiol is again natural estrogen, so we like this combination. So as you can see, the first half of the cycle, it's different color because it has got only estrogen, and the second half of the cycle has different color, the blue one, that has got, each tablet has combination of estrogen and progestogen. In comparison to the continuous combined, whereby, as you can see, it's only one color, every tablet of the 28-day tablets is the same preparation, which is low dose of estrogen and progestogen. Continuously, we use it in this manner, so inducing no bleed, and at the same time, we're giving it for those women who stopped having periods for 12 months to ensure that we will not resume any kind of bleeding. So, I'm giving you the Femostin Conti as example. And in this manner, I tried to reiterate this important aspect of the endometrial protection in more than one method, audible, of course, and visual here, so you are quite clear, I hope, about it. This slide here, I put it for information. You don't need to learn all these doses. There are few slides just for lateral knowledge and for information to have more holistic approach of the HRT. This slide is telling you about the types of estrogens we have now, and we like more the natural ones like the estradiol, the top two, estradiol and the estriol. So they are more resembling the natural estrogen that is produced physiologically by the ovaries, and they are derived from plants like, for example, the yam or the soybeans, in comparison to the conjugate estrogen that is synthetic estrogen that was in the older HRT preparations. So I'll pause one second and I'll ask you, what is the main indication for HRT? Yeah, correct. If you are thinking that it is for the treatment of menopausal symptoms that are mainly the hot flushes, the night sweats, and the lack of sleep, the success rate is quite high, in excess to 90% reduction of those symptoms, and the evidence is type 1, which is randomized controlled trial. And the types of estrogen I already covered, just to add that ethinyl estradiol is synthetic one, and you find it mainly in the contraceptive pills. And that's only for information as well. This slide here is for info. I will not go over it except to say that there is a preparation that gives period every 3 months. We use it for the perimenopausal women. However, because the 12 or 14 day of progestogen every 3 months, we don't think it is really going to provide endometrial protection as efficiently as the cyclical monthly ones. It's now less utilized, and the preparation is less favorable. Also, I put here at the end Tibolone. The trade name is Livial. It's not HRT or hormones, it's rather steroid, but can work well on menopausal symptoms. And I left it for you also for information. The 2 lines at the end are important, and I have reiterated them more than once. Similar to what I said about we like the natural estrogen, in similar manner, we move towards more having natural progesterones called micronized progesterone, which is progesterone resembles the one produced physiologically by the ovaries. It's sourced from plants, and it's thought to be more acceptable with the fact that it resembles the physiological progesterone, the natural ones. It is licensed orally and vaginally, the systematic reviews evidence suggests that it is safer for breast. As you know, the modern understanding is that progesterone can be linked with breast cancer, not just the estrogen, and therefore the only role the only role for progesterone adding it is for endometrial protection. Otherwise, there is no role for progesterone in hormone replacement therapy. So the advantage of the micronized progesterone, as because it is natural or resemble natural progesterone, it is safer for breast. And as I said, the evidence is type 1 evidence systematic reviews, and that is looked at for 5 years, and it may be more than 5 years, but we still need to have the evidence. But logically, it is likely also for the effect of protection to continue more than 5 years. It has cardiovascular benefit and does not alter the glycemic control, so can be more friendly with diabetes. It is convenience as well of using it, because you can add it separate to estrogen patches, tablet or gel. And the very modern now way of prescribing HRT is to give estrogen gel, 2 pumps every day, and to give the micronized progesterone called Progestan, 100 or 200 milligram continuously every day. So to summarize the progestogens, the top 2, the micronized progesterone and the dihydroprogesterone, are more natural ones, while norethistierone is synthetic and more testosteronic based. Levonorgestrel is mainly in the Mirena coil or the hormonal intrauterine system. Norgestrel and medroxyprogesterone acetates are all long been in the market, and they are synthetic. So the top 2 are more natural one and more favorable to be used now. This slide about the common side effects of estrogen and progesterone. There is overlap, as you can see, but mainly progesterone is associated with low mood or mood swings and the skin symptoms. The next 3 slides is about mechanism of action of the progestogenic side effects, and you can read it again. It's self-explanatory and useful. Right, this slide summarizes all the recent advances that are available on the market now with examples, and I would like to leave it for you to read it slowly. Mainly, I wanted to say that Estradiol now, we do it in the form of transdermal gel. As you can see, maybe 2 pumps a day, and we can add the natural micronized progesterone, which is called Progestan, 100 milligram or 200 milligram, and you can read the rest, but this is the more modern way of giving now HRT. So estrogen patch or gel daily plus natural progesterone, micronized progesterone, Utrogestan, 100 milligram or 200 milligram tablet again daily. And if we want to do it as cyclically, then we do it for 12 or 14 days every 28 days. I hope that's clear, and you can read the rest. Okay. Okay, and this slide, you don't need to memorize everything. I just give it as also lateral knowledge. Maybe you can pick on one of the preparation and learn it. This is important because vaginal dryness, vulvo-vaginal atrophy, VVA, is quite common and underreported and can actually impact women's life. And with simple replacement, with actually quite safe approach, we can improve the quality of life of women. So here are a few examples and few doses. I would like you maybe to learn about the vaginal pessary Imvages. This is a new preparation, 3 microgram. We're talking about 3 microgram estradiol. And there is no inserter, so it's more eco-friendly. Obviously, the creams, look at them. Ovestin, Gynest, you can find them in the gynae clinic all the time. And the two things that I want to draw your attention to, you may hear about them. This is very recent advice. The first one is the DHEA, dihydroepiandrosterone, and that is maybe helping for the libido when it drops down with the menopause. And the other one is ospemifene, which is SERM. And SERM, we said it is selective estrogen receptor modulator, that it's a novel now treatment for vulvo-vaginal atrophy. It's tablet, because some of these ladies find it difficult to approach the area down below with the severe atrophy and the soreness down below. So tablet can be more appealing to them. And this is, again, very new knowledge, and it's important for you to know about it. I hope that is useful. So this slide is useful to learn as well. I just want to give you some idea about what is the daily requirement of estrogen in healthy women. And maybe if you want to look into the medium, so you are not going to use ultra low, low, medium, and high. If you try to learn some of the doses of the medium. For example, all my life, I know that the estrogen is probably 1 milligram to 2 milligram daily requirement of in the healthy women. If you remember that, then you can actually see what is the equivalent in the patch. This is 50 microgram, the medium patch, microgram. And the gel is the pumps 2, and the gel sachet, which is some gel in a sachet form, is 1 to 1.5 milligram. So I hope also that gives you some idea. You don't need to memorize it all. When I was medical student like you, I knew the one thing that is really clear in my mind, that the requirement of estrogen for women, daily requirement, is 1 to 2 milligram. Okay, so if you learn that, I think that will take you through other things, because you can check with the BNF and other things about equivalent doses when you move to patches or gel. Yeah, but here, if you concentrate on the medium sort of doses, you will not go wrong. At least, for example, the oral 2 milligram, the patch 50 microgram, like for example, Evorel patch 50 microgram, and the gel is 2 pumps. If you remember that, that will be brilliant. And I will leave you with the thought of this future precision medicine based on pharmacogenomics, and how we can personalize the management or patient treatment by looking at adjusting the dose based on the identification of the genetic variants in the enzymes that is involved in the hormone metabolism. The reference is there if you want to look for it further. And we come now to the end of the talk. Thank you very much. I hope you find this talk useful.